Okay, thank you, everyone. Let's start to present the last speaker on this session from Professor Cranston. This is a recorded lecture. So after the lecture finish, we can move to another session. Please.
It's a great pleasure to be with you virtually. I'm sorry I couldn't be with you in person as I'm currently traveling in the United States. But I would like to share with you the experience that we've had in Oxford of high intensity focused ultrasound over the last 20 years. We started back in 2002 and have had a very good relationship with the HIFU Center in Chongqing in China. So Oxford, that many of you may have been to, is called a city of dreaming spires. And it has been a great privilege to work here during my consultant life. Certainly, if any of you are able to come at any stage, please get in touch and we'll be delighted to show you around. So we started off in 2002 in this building here on the left with this machine, the JC200 Chongqing system. And this is what we got CE marked for Europe. And we're using initially for liver and kidney trials. Over the last 10 years, we've been in this unit. Fortunately, this is part of the Churchill Hospital. Unfortunately, it's not the whole HIFU unit, but this is the Cancer Center and Radiology Center. We have a room here where we have the JC200 machine. So it was William Osler who lived in the 18 and 1900s that said diseases that harm require treatments that harm less. The old adage, primum non nocere, first do no harm. And I remember being very impressed when I first went to China to see William Osler's picture up in the HIFU Center and seeing his work there and that quote there. So, as I'm sure you're aware, high intensity focused ultrasound tends to look at the focal point rather than the image. Ordinary ultrasound, you put the ultrasound beam into, for example, a kidney here, and then you're looking at the image. But even with ordinary ultrasound, you get a very small rise in temperature at the focal point. And if you put the power up 10,000 times, then you move through therapy to killing and ablation of the cells. So there's also been a lot of preclinical work in Oxford being done over the last 20 years by Professor Konstantin Kousios in the Department of Engineering Science, based in this green building in Oxford. But for the clinical point of view, we have been looking at a number of different things: uterine fibroids, liver and kidney. We've treated a couple of patients who've had renal transplants with tumors in there, prostates on a different machine. But we've also looked at sacral chordomas and starting trials on pancreas. And we've treated one patient who's had subcutaneous abdominal metastasis from colorectal carcinoma. And a number of these treatments have been funded by trials. These are the HIFU ablation, the targeted drug delivery. We're hoping to start a trial on breast shortly, and also start a trial on metastatic renal cancer. But we've done work on primary renal cancer and also sarcomas. And then part of the experimental stuff looks at neuromodulation and also prostate cancer, and looking at the immunology in both experimental and now starting to look at immunology in the clinical setting, and also fat absorption as well, because part of the problem with the kidney is that the fat absorbs the ultrasound beam and you get less delivery, less targeted delivery at the focal point. So initially our trials getting the machine CE marked for Europe were in liver and kidney cancer. We were looking at the safety and the toxicity of HIFU, and secondarily the performance of HIFU for the treatment of these cancers. In the trial groups, this was back in the early 2000s, we had 56 patients, and we had a number, as you can see here, in liver tumors that were non-surgical. In other words, they were ablated and then looked at radiologically. but then there were some that were ablated and then removed just to look at histologically. Likewise, in kidney tumors, some that were ablated and removed, others that were ablated, and we just looked at the non-surgical effects radiologically. So we do get occasionally some problems with blisters on the skin with a prefocal thing, but not that often. And here we have the first patient that we treated in Europe. In 2002, she was a lady who had metastatic colon cancer with secondaries in the liver, and she very kindly allowed us to treat one of the lesions in the liver. And then that was removed later on after she died at post-mortem. And that was the first patient that we had done. Here's the early team, David Wild, who sadly died of a brain tumor, and some of my colleagues, James Kennedy, who basically was instrumental in getting the whole program started with me, who's now slightly changed direction and has become a minister in the Church of England in the nearby Chipping Norton village. Professor Wu has been working extensively with us over the last 20 years. Roland Illing was a research registrar who's now in the United States in Washington, working for Amazon Web Services. So here was the early publication in the British Journal of Cancer in 2005, looking at the safety and feasibility of it in a Western population. And here was the CE marking in 2005, approved out of China. And so we had a number of ongoing trials following that, clinical trials looking extracorporeally at renal masses and small renal masses. We had a laparoscopic trial just looking at that as a proof of concept thing. Of course, with laparoscopy, then that's not totally non-invasive. So you have to make a hole in the abdomen, put the laparoscopes in, and then treat with that. And then we've looked at these translational things, the assessment of acoustic properties of perinephric fat and immunology and passive cavitation monitoring. So here's just a summary of some of the work that we did with the kidney. 17 patients who 15 completed treatment, 2 for various reasons was abandoned. And of the 14 that were completed, only 1 then went to surgery. 10 remained under surveillance, 4 had other treatments, some ablation, and radiofrequency ablation, or indeed 3 of those did have surgery. But this just showed the anesthetic time, but the on time actually firing the HIFU was 21 minutes. And over the coming years, that's going to get shorter, and so that we'll have much less, I think, anesthetic time and faster treatment times. Here's one of the early ones that we did with a primary renal tumor. Here you can see, and then after ablation, totally gone, no uptake at all. And then over the succeeding follow-up in years, we had continued good absence of contrast there, and even 5 years later, no take-up there. So this was one of the early successes. Here's the laparoscopic renal HIFU. As you can see, it's not non-invasive because you have these machines in. And this was using a transducer on this machine with a focal length of 3.5 centimeters. The extracorporeal focal length is about 14 centimeters. Here is a patient with a large renal tumor. And this was after the laparoscopic HIFU. You can see the ablation there. So, of course, it's effective, but sadly not non-invasive. So we didn't continue with the laparoscopic HIFU. So fat is a problem. Both fat and ribs were a problem with the renal tumors. And here you can see a CT scan, and here's the fat layer. And you can imagine that as the HIFU beam goes through that, it gets distorted and absorbed by that, which indeed is what happened, which meant that it was, but certainly with people who had quite a lot of fat around the kidney, much less effective. So we took 10 patients who were undergoing renal surgery, and we took a sample of perinephric fat that was removed intraoperatively. We put it into a saline water bath at 37 degrees centigrade, and then performed the experiments on it, measuring each sample placing different thicknesses of fat between transducers. And this is what we found, that with 2 centimeters, the intensity of the output was decreased by 58%, and 5 centimeters, only a quarter of the intensity is actually getting through to the tumor. So I'm sure that can be adjusted for in due course, just as we know that brain HIFU now, our physicist colleagues are very clever at working out the distortion of the beam as it goes through the skull. And therefore you can use a non-focused beam outside the skull, which then becomes a focused beam within the skull. And I'm sure that that is going to be possible with the kidney in due course, and working out the absorption and how much you need to change or increase the power to get it into the tumor. Now, if you look at a renal transplant, of course, then you may or may not know that this is different, because when you take a kidney out and you transplant it, what you're doing is removing the perinephric fat and you transplant it down in the groin. So the ribs are not a problem and the fat is not a problem. Here's a tumor in a renal transplant, which we treated with HIFU with virtually total ablation. We did go on and take it out afterwards with the margins as well, just to make sure we had all the margins, and we found 90% ablation, and just the margins had not been ablated. So if we look at fibroids, which of course is the has been the major indication around the world, or well, not necessarily the major indication, but certainly the one that is most used around the world. You know that it's a common disease in women. Surgery still remains the main modality in many cases. But here, for example, is a fibroid which is being treated, and you can see that there is no contrast uptake in it there. And we worked quite closely with China and the 20-center study that was done in China in creating and drawing up the guidelines for this and helping to write the paper for this. So here were 2,400 women treated with symptomatic fibroids around China, and with help from Chongqing, with the Chinese Cochrane Center, with the Surgical Interventional Trials Unit in Oxford, and the Nuffield Department of Surgery, we put together this paper looking at complications, hospital stay, return to normal activities, quality of life, and the need for further treatment. So we found that 1,353 women received HIFU, 472 had a hysterectomy, 586 had a myomectomy. And both the quality of life and the symptoms improved more rapidly after HIFU than after surgery. And the major adverse events were much smaller in the HIFU group than in the surgical cases. Hospital stay was shorter in the HIFU group, and certainly most people who treat fibroids, the patients can go home the same day or the next day. And I think the reason why they stayed longer in China was the distances that they had to travel to get back home. So this was written up in the British Journal of Obstetrics and Gynecology a couple of years ago, and had a major impact, I think, internationally in the raising the profile of HIFU for uterine fibroids. We treated a few patients in Oxford, we've treated some more since then, but again, similar effects. And we had the symptom scores which were increasing after, which were getting better after treatment, and the volume was shrinking. And of course, some of them do slowly recur, but of course, unlike radiotherapy, not that that's used for fibroids, but unlike radiotherapy, if the symptoms come back, if the fibroid regrows, then you can just retreat. So as a result of that, we went to NICE, National Institute of Clinical Excellence, and we managed to get that approved, subject to certain restrictions, in 2019. And that's just come up for review again. And although on the website, the guidelines are just the same. I've just been in touch with them recently, and they are actually reviewing what we've sent to them. One of the problems was that they thought the incidence of skin burns was very high, but that was a false understanding of the literature, and we've tried to correct that for them. So we hope that they will broaden the guidelines, but we're waiting to hear what the review will show. Now, we have done work on prostate on a different machine from the JC and the JC200 machine. It's a transrectal machine done under general anesthetic, and there are an increasing number of studies that are showing the effects are as good as other localized treatment. In prostate cancer, you can't look at mortality because especially the localized prostate cancer, all the evidence is that if you're treating localized prostate cancer, you need to look at least 15 years ahead to see whether your treatment's made a lot of difference, because most people who are not treated will live 15 years or longer. So with localized prostate cancer, mortality is not a good indication of the disease. You've got to look at other parameters. You can look at the PSA, you can look at the side effects. So I won't talk more about prostate cancer at the moment. There's a lot of literature there on it. But sacral chordomas is another area that we've treated in Oxford. Now, sacral chordomas are not malignant as such, but they are locally invasive and can be very debilitating and difficult to treat. Here, for example, is a patient who had large sacral chordomas on the buttocks, and here, such that they could hardly sit down. We treated one side, see the ablation there, we treated the other side, and here, after HIFU, let's just show you that again, ablation there, and it gave a lot of symptom relief, and the patient was able to sit down afterwards. This was written up. We had a national trial of this, and we treated a number of patients and wrote that up in the neurosurgical journal as a treatment. So let me turn to targeted drug delivery. One of my colleagues, Paul Lyon, did his PhD on this in Oxford and looked at the safety and feasibility of hypothermia. So it wasn't ablation as such, it was looking at hypothermia, just raising the temperature in a tumor a secondary tumor in the liver to 42 degrees centigrade, and then using targeted drug delivery. So what we had was thermodox. So that is liposomes, which are a little bit like butter. They are stable at 37 degrees centigrade, but then break open at 42 degrees centigrade. And into them is put a cytotoxic drug, doxorubicin. And then what you are basically doing is heating up the tumor to 42 degrees centigrade, injecting the drugs peripherally, and then at 42 degrees centigrade, these break open, the doxorubicin is released, and you get high delivery specifically to the target. And here were the endpoints, the total intratumoral concentration, but also looking at safety, at the hypothermia, at the cell viability, looking at the radiological response and the distribution of doxorubicin. So here we have a patient and take a biopsy of the tumor, the secondary tumor in the liver, and then you're introducing thermodox peripherally into the vein, and then as it goes in, you're then heating the tumor to 42 degrees centigrade, and then measuring it and also taking biopsies afterwards. But as the drug passes through, then you're getting targeted release there. So safety-wise, fine. We got neutropenia in half the patients. The hypothermia was well controlled, and the drug delivery enhanced between 2- and 9-fold. And a very good radiological response. So it's quite interesting that doxorubicin is not particularly effective in colorectal cancer, but if you can increase the dose specifically to the tumor, then it does become effective. And here we can see the take-up of secondary tumor. And here's one that we specifically looked at. This was the area that we raised up. And you can see that how it has destroyed the tumor at that particular spot. So here again, you just heat up an area of tumor, and then you can see the effectiveness in destroying it afterwards. So 9 patients. So we had very positive results in 4, and another 2 developed photopenia, in other words, demonstrated good treatment. And this was written up in the Lancet Oncology in 2018, a first-in-man trial of this. So turning to pancreas, we've only just started recently treating pancreas, both in an ablation sense and with targeted drug delivery. But we have also, at least Professor Wu has treated 8 patients with unresectable cancer for pain, and had found pain relief in all of them, with survival times. I think that it's difficult to say whether the survival changed at all, but certainly the pain relief was very good. And this is a little bit more difficult to see, but one of the patients we treated in Oxford with some drug, some contrast uptake here, which has disappeared 3 days after HIFU treatment. So I will just finish with this. I think this is good for all those who are involved in HIFU research. It's a quote from Theodore Roosevelt. I will read it to you because I think it is good. And I think when people are perhaps questioning HIFU and indeed any early research, sometimes you feel as if you are pushing a stone uphill, and it's very difficult initially in the early days of research. But if you persist, eventually you get to the top of the hill, and then hopefully it starts rolling down and gaining momentum on the other side. And I think that is what's starting to happen now, more so with HIFU. So let me read this to you. It's not the critic who counts, not the man who points out how the strong man stumbles or where the doer of deeds could have done better. The credit belongs to the man who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, because there is no effort without error and shortcoming, but who does actually strive to do the deeds, who knows the great enthusiasms, the great devotions, who spends himself in a worthy cause, who at the best knows in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who know neither victory nor defeat. I think that is a wonderful quote for all those who are involved in the trials and tumults of research. So many thanks to many people who have been involved in the work in Oxford. I won't name them all, you can see them there. Clinical research fellows, preclinical people, other surgical colleagues, and of course, the National Engineering Research Centre for Ultrasound Medicine in Chongqing. So thank you very much. And I hope next time I can be with you in person.
Thank you, Professor Cranston.